Hello everyone. Welcome to EPG Pathshala today. I'm Dr. Janvi Tandon, retired professor from the Department of Community Medicine, Institute of Medical Sciences, PHU, and we'll be talking to you on the National Program for Healthcare of the Elderly. The development team is Dr. Mishra, headed by Dr. Mishra, and his team of consultants from all over the country. Now, learning objectives. When we are going to talk of healthcare, a national program for the healthcare, especially for elderly healthcare, we need to find out certain things, that is defining the pediatric population, and we need to state the problems of which these people are likely to face. Then we need to describe how this program about elderly came about to become a national program. We need to enumerate the key components and, of course, state its present status of implementation. Now, what is the definition of an elderly? Definition of an elderly as given by the Government of India on a national policy on older persons in January 1999 described a senior citizen or an elderly as a person who is of 60 years and above. We must remember that all of us have to grow old, and old age means different problems, different aspects of life for different situations. Now, aging of the population is definitely affected by many factors, and most of them is the modern day downward trend in fertility and mortality. What with the healthcare programs coming in, information, education, and education being disseminated through all different types of medias, people tend to understand, learn, and take proper steps in order to control their health as well as their family growth, depending on the income of the family. So therefore, if the fertility is going to go down, and as a result of good care and general health, mortality is going to go down, the aging of we will get a larger population, a higher population of the aging people. Then besides, with very good control programs in community healthcare, especially for bringing down maternal mortality, infant birth rate, and general fertility rate. So low birth rates coupled with lifelong expectancy is contributing to greater degree of aging population. Now, India is definitely facing a big problem due to the huge graying population who may be far poorer than their counterparts abroad. Definitely, and because it matters, it actually is dependent on a lot of factors. For example, in India, the financial security for the elders is greatly lacking. Now, why is this? This is because of the rapid change in the social scenario and the emerging prevalence of the nuclear setup. Now, families are growing, interests are growing, needs are growing. So, therefore, the factor that they have to earn more money is growing. So, what is happening is that people are, in order to earn more money, to save more money, to have more facilities in the family. Now, the nuclear family setups are coming up in India as a result, and all over the country you can see, whether it is Bangalore or Bombay or Delhi or Madras or any of the metro cities, you find the children have grown away and weaned themselves away from their families and have taken their small family units to places where they are working so that they can, both husband and wife, start to work. So when both husband and wife are working, the child is to be left alone in daycare centers. Now, this is where the real problem is creeping in. The elderly people in the family who have been left behind in their custom homes or in their rural areas are now being brought forth in order to help this young couple to live a comfortable style. Besides, this is not only in India, but this pattern is now being set up abroad, where lots of mothers and fathers are traveling to US and to other countries to help their their children settled in a nation where they need help from these people, and that too at very low paid, in fact no pay, because parents are parents, they will not take money to help their children, and this is an emotional factor. So elderly people, when likely to be exposed to emotional, physical and financial insecurity, are likely to depend on whatever their children say. Now, the pediatric population, which was 7.7 in 2001, has increased nearly up to 8.14 in 2011 and is expected to go up to 8.94 in 2016. And with the rising life expectancy and the new lifestyles, the proportion of the graying population is expected to grow more. Now, what is the issue of challenges as far as the pediatric diseases are? The growing pediatric population has increased in magnitude, and with it, the diseases which affect the various parts of the body as we grow older, growing to a larger number. Now, many of them have especially non-communicable diseases, and it often leads to disability of all sorts. And this is where our national program is needed to be able to reach these older people and help them to lead quality lives, at least useful and quality lives. Now, in these, you can have diseases of the eye and the ear, you can have strokes, you can have CVS, you can have, these people have blood pressure, they have joint locomotion difficulties, and with this, of course, with the process of aging, men are likely to get prostate enlargement, and women are likely to get backache problems. So with all these, definitely some sort of care to be given to these people in as far as possible through the outreach areas is needed. Now, these chronic, disabling and multiple health problems need different approach and management. Now, let us see what this can be. How did this program, what is the evolution of this National Health Care for Elderly program? You see a picture before you of a beautiful apartment building and a senior elderly person being helped by a young, energetic person on her wheelchair, and both seem to be happy. Now, this is the new trend. What is this new trend? Those people who have money have been able, now these new apartment homes or these new nursing homes are coming up, which are absolutely well equipped. And many of our older people, the aging citizens, have bought themselves places to retire and to live their life completely till the last days. There they have complete security, they have help, and they have other people to talk to communicate, and this is where they keep happy instead of being at the beck and call of their children or the community where they have actually grown up. Now, the United Nations World Assembly on Aging, in fact, this is the beginning of this program, held at Vienna in 19. It formulated a package of recommendations which gives high priority to geriatric research. Now, the moment this was given out, all the countries started paying attention to the geriatric population, and thus in 1999 we celebrated the International Year of the Older Person, and in the same year the Ministry of Social Power and Empowerment of India promulgated the National Policy for the Older Person. In fact, in 2006, a working group on the Planning Commission recommended a national program in 2007 for the maintenance and welfare of parents and senior citizens. This was also passed. So we can see slowly how one conference in 1982 led to the beginning of the National Health care program for the elderly. And this is exactly what is needed today. Because in fact, till now, the elderly population has been the one which has been the most neglected. All attention is paid on a family which is living, acting, and moving day to day. So these older persons who are in the background were being forgotten, but not today. Keeping in view the recommendation made in the National Policy on Older Persons, the Ministry of Health and Family Welfare formulated a national program for the health care of the elderly during the 11th plan. Then the Government of India also decided that a Department of Geriatrics was to be created in all medical colleges, and efforts were taken to involve all the NGOs into the program at the grassroots as well as at the medial level. Now, to provide an easy access to promotional, preventive, curative, and rehabilitation services to the elderly through the community-based primary healthcare approach was one of the main keyholes. So that particular line of administration, that is from the district to the community-based to the primary, to the sub-centers, to the primary health centers, became a very important line in order to distribute equitable and accessible health care to the elderly. To identify health problems, this was also important, to identify health problems amongst the elderly and provide an appropriate health interventions in the community with a strong referral backup, which is very essential. And most important, to build a capacity for the medical and paramedical professionals as well as caretakers within the family providing health care, because eventually these medical and paramedical professionals will visit, but they will move out. And so what remains is the caretaker within the family. So he or she is to be taught how to handle the elderly in the family. And most important again, to provide referral services to the elderly patients through the district hospitals and regional medical institutions. So therefore, one whole series of steps has been created wherein the elderly person in the field level can be taken right up to the district level for an advanced and proper care which would be needed. Community-based primary health care now, what are the core strategies of this? Core strategies were based on some important facts. Community-based primary healthcare approach, including domiciliary visits by trained healthcare workers, very important. Then dedicated geriatric service at the PHC and the CHC, Comprehensive Health Center level. Then dedicated geriatric facilities at the district hospital with 10-bedded wards. So 10 beds would be at the district hospital, and finally a strengthening of 8 regional medical institutes in the country to provide dedicated tertiary level medical facilities, which would include all sorts of technical help to the elderly, coming to them for help. And these places would contain 30 beds. And of course, the stress on using information, education, and communication for awareness in this regard right down the line was absolutely essential. Now, what were the supplementary strategies? Supplementary strategies was to find people who could, at the intersectoral regions, who could participate in providing very good geriatric health care and help in understanding what these issues were. For example, promotion of public PPP, that is the public-private partnership in geriatric health care. Then most important, Ayush, mainstreaming Ayush and revitalizing the local health traditions and converging it with the programs of the Ministry of Social Justice and Empowerment in the field of geriatrics. Now, what is Ayush and why? 1995, Ayush was started as a department. Ayush means it consists of all the traditional methods of medicines which have been available in our country, that is Ayurveda, Unani, Siddha, and homeopathic. And these all have good medicines which can be utilized without harming the elderly, the fragile elderly persons coming in for treatment. So we try to include these. And finally, Ayush, which has become a ministry in 2006, has now taken full participation as far as giving a good strategic approach to healthcare for the elderly persons. Then reorienting medical education. Now, this is an institutional framework which tells in a very nice triangular frame, that is at the topmost is the tertiary level, or let us start at the bottom. Bottom is the home-based care at the sub-center, looks after the population, 5,000, 10,000 population at the field level. The patients come to the sub-center, and if needed, they are referred to the primary health center or to the community health center, and wherein doctor sits and on fixed days, and these people can go in for consultation and for necessary treatment. And then comes the district hospital with its advanced technology and advanced framework of highly trained doctors to look after the geriatric clinic and the geriatric ward, because there is a 10-bedded ward. And finally, at the tertiary level, that is at the medical institute level, we have the 30 beds with the full supported by the full medical college technology. Now, let us see in detail what these sub-centers are going to give. The sub-center at the grassroots level, serving a population of about 5,000, 10,000, here we have to give domiciliary visits, that is home visits by the A&M or the male health worker to the homebound or the bedridden elderly persons. Now, because these are small populations, all the families are known, and there is a list of these elderly persons who need special care. Then there, when they are visiting them at home, if they so need, they can arrange for suitable help, for suitable calipers or supportive devices in case they need to walk with a supportive stick or any supportive device which is needed. And from the primary health center, they get this supportive device, give it to the elderly person at the level, to make them ambulatory. And of course, health education to how to use, to be careful so that they don't hurt themselves more than what is essential. The next level is the primary health center, primary health care center. This program has been envisaged in only selected 100 districts. Now, in the primary health center, they have weekly geriatric clinics run by a trained medical officer and with the provision of medicines. And they give different awareness teachings on different aspects of geriatrics. And if they are needed, these patients can be referred higher up, or they can be treated from the primary healthcare center itself. Now, when you come to the community health center, which is the next level, here we have geriatric clinics for the elderly twice a week, so on fixed days. And of course, there is a very good rehabilitation unit for physiotherapy, which is very needed for making these people active. Then domiciliary visits by the rehabilitation worker for the bedridden, medicines if needed, supportive treatment if needed, and finally referral to the higher centers if it is needed from the community health center. And of course, with the community health center has 10 beds, so in case admissions are needed, they can be admitted. Now, when you come to on the general bed, but in the district hospital, you have actually 10 beds which have been allocated in the geriatric ward for inpatient care of the elderly, for those who are in need of critical care. Geriatric clinic for regular dedicated OPD services. Now here you may have patients may report every day. There are no fixed days. And you have, since it's a district hospital, you have very good laboratory investigations, and there is a good provision of medicines for these patients. Besides, you have, in fact, a direct attachment to specialists in general medicine, orthopedics, and other services which might be needed. Ophthalmologists are there, and these also conduct camps for geriatric services in lower down, that is in the PHCs or in the other sites. So they collect these people, look after them, carry out healthcare, and of course, at the same time, is supported by the education techniques. Most important, the highest center, that is the regional geriatric centers. These have been created in 8 medical colleges throughout the country. For example, some of them are All India Institute of Medical Sciences, New Delhi, in fact, Institute of Medical Sciences, BHU, and you have it in Kashmir, you have it in Trivandrum, and you have in Assam, Tamil Nadu, Jodhpur, and you have Grants College, Mumbai. Now, what do these centers do? These centers have specialized geriatric clinics, and especially for the elderly and for the persons who have been referred from down the line from the primary health center or from the CHC. These have been given 30 special beds for geriatric patients themselves, and patients for various specialties for needing various help are admitted. Surgery, it could be surgery, orthopedics, psychiatry, ophthalmology, or etc. Then, since there are very good labs, so laboratory investigation for the elderly can be done very comfortably, and tertiary health care to these cases referred from the medical colleges, district hospitals, and below. Now, the National Program for Healthcare of Elderly Guidelines, and for the functions of the non-communicable diseases cell at the center. Preparation and dissemination. See, for all this, teaching material has to be made so that it could be disseminated and sent to the technical and operational guidelines on all aspects relating to geriatrics and implementation of the national program. And there is a plan for capacity building. You need to train your workers and the health functionaries in the healthcare system at all down the line, that is at the primary, secondary, tertiary levels, including developing various training models so that these are properly trained and guided to serve the population for whom they are meant. Now, most important is that for any national program, you need a proper coordination and a liaison with all the stakeholders who are interested in this department and in the program. So therefore, monitoring, review of the program activities have to be held at each level, and they have review meetings and field observations so that mid-course corrections could be done very comfortably, and this change in course could lead to better results. Then the release of funds and monitoring of the expenditure is also to be done, very important economic aspect, and organizing and this. Now, in the present status of implementation, you have very good institutes where the elderly can be given very good rehabilitation and training program, and they learn how to live their lives in a very safe manner. Now, in the present scenario, the non-communicable disease cell or the geriatric cell, whichever is applicable, will be responsible for supervision and monitoring of the program, but at the state level. But the activities of the regional medical institutes will be monitored only by the center, that is the Ministry of Health and Family Welfare, in coordination with the state geriatric cell. Now, it must be also stated that fairly a large amount of money is being released for this program so that education, technical material, technical guidance, training, management, empowerment can be done at with proper efficacy. So an amount of 153.40 crores has been so far released to the participating states for the program in 10-11, that is 2010 to 2011, and the implementation of the program for establishing the 10-bedded geriatric units in the district hospital. Besides, some more money has been released to the 8 regional centers where the 30 beds are there. And it is also said that it is proposed to cover the remaining districts of the country during the 12th five-year plan in a phased manner and increase the 30-bedded centers to at least 12 more regional centers in selected medical colleges of the country. And this is also has to be taken up. But before we end, I'd like to say that the problem of taking care of the elderly is a very, very important problem. Those elderlies who have retired from proper services where they are having a pension and medical care services are good. But those people who have not worked in such a situation and are ultimately at the end of the day, in the evening of their lives, are dependent on their children, it is a very sad situation unless some medical aid, education, and selected efforts are made to look after them so that they live their lives in a happy and in a satisfied manner. So with this, I extend my heartfelt thanks to all of you for visiting this particular lesson. At the end of this lecture, I would like to show and share a small clipping to explain the meaning of the care for the elderlies. Shall we see the clipping?
पिंकी पिंकी
जी पापा।
मम्मी को दे दो
समोसे।
एक मिनट ये दादी के लिए।
मेरी दवाई लाए?
हाँ।
ओए पिंकी, क्या है?
दवाई।
पिंकी जा पापा से पूछ क्या वो कितना लेंगे।
पापा आपको दो दूं?
नहीं एक ही देना और जरा चाय का भी देखना।
हाँ हाँ मम्मा बना रही है।
ये नथुराम का है क्या?
हाँ दादी नथुराम के।
ये लीजिए एप्पल।
पता नहीं अब कैसे बनते होंगे।
वैसे ही बनते हैं माँ, जैसे पहले बनते थे।
पहले तो यूं बड़े बड़े बनते थे, असली घी में बनते थे, उसमें बादाम डाली हुई रहती थी। पता नहीं अब कैसे बनते। पिंकी
जी
एक टुकड़ा देना मुझे, थोड़ा चख लूं।
कुछ नहीं मिलेगा आपको।
एक टुकड़े में क्या हो जाएगा?
क्या हो जाएगा? क्या मतलब क्या हो जाएगा? उल्टा सुल्टा खाते रहती हो, तबीयत खराब करते रहती हो। हमें और कोई काम नहीं है? कभी चिक्की छुपा के खाती हो तो कभी भुजिया, चाहे लूज मोशन की नदियां बहती रहे।
100 बार सुना चुका है।
अब बच्ची हो, कुछ समझ नहीं पाती हो।
तू अकेला ही समझदार है, मुझे कुछ आता ही नाही, जैसे यही अकेला समझदार आहे. कुठे जायचं, काय करायचं काही कळत नाही. एकटा जीव म्हणतात सदाशिव, काय करायचं. जायला पण कुठे जागा नाही. ही मुलं सगळे मागे लागतात, हे नको खाऊ ते नको खाऊ. कुठे जायचं, कुठे उभं राहायचं, कुठे राहायचं.
Welcome back, and hope you really enjoyed the clipping, because let us put forth certain very important points. These parents who have worked hard in their lives to bring their children up, to give them all facilities, to educate them, and most important, they felt free to let them cut, to permit them to fly as they wished and to as far away as they wanted, and enjoy and see life as they would want their children to see. But at the end of the day, it is very important for us children and for you children to remember that whatever said and done, your parents have grown old now. They need that stick to walk, and let that stick be you. You and your family should never abandon your parents to a life of misery or sadness or of uncared life in their old homes. And it is better to give them the support of which they would remember during their lifetime. And even if one is far away, be in touch with your parents regularly. And most important, give them this salute for that beautiful life which they have led, and give them a wonderful evening of their lives so that they remember and they pass the rest in safety, comfort, love and affection from all of you. And for attending the EPG Pathshala, so my all best wishes and good day. Thank you.